by a number of different communities across geography, ethnicity, and experience. Next slide, please. So many of you have likely written about community health workers, as Sonita mentioned, may have had deep experience in your own culture or community. You will find us here in the United States working around community violence prevention in emergency department facilities. You may find us helping new immigrants and refugees navigate new health systems and eligibility programs. You may find us conducting home visits or working with families to ensure immunizations or oral health. You can always find us at our state and local governments lifting up legislation and amplifying our roles. As the APHA has acknowledged CHWs as frontline public health workers, we have deep cultural origins that obviously extend as diverse as the United States is throughout the world, with deep sort of cultural experience, health beliefs, and religious practices around health, as well as shared experiences that are born and sort of tested here in the United States. Community health workers are those who have a calling for compassionate service. We accompany, we walk alongside, we partner with, and engender trust with our community members. We often live in the community, or we are peers with the same lived experience. We are HIV positive, we are living with chronic disease, we are cancer survivors, we are from the reentry community, we were once migrant health workers, etc. And to that end, we conduct a range of roles and skills and competencies that allow us to pursue improvement of whole health well-being, as well as to advocate for and impact systems change and drive social justice and equity. Next slide, please. I want to first emphasize here that CHWs are a precarious workforce. We are disproportionately female and females of color. We are often peers and survivors of many of the barriers to the social determinants of health or social drivers of well-being that many marginalized communities experience. Oftentimes, our funding reinforces this reality. CHWs often work in short-term grant or project-based funding. We are among the lowest paid out of all public health frontline workers. And often we are focused in programs and interventions that are reflective of and in fact are sort of impacted by the marginalization, the sort of siloed sectors that are persistent throughout the United States, and the historic sort of structural racism that has embedded itself throughout our systems and policies. We work in under-resourced communities often in a variety of different settings and across every sector. So you will find us as liaisons in education. You will find us working on the opioid epidemic. You will find us working upstream around housing and immigration, workforce development, as well as working in hospital systems and with primary care providers. We are bridge builders. We are navigators. We are health educators, but we are also community organizers and researchers and advocates. Next slide, please. So I just want to share here some bright spots from across the country. As a member association of CHWs and CHW organizations, over the last several months, beginning in March, the National Association has been culling the knowledge and experiences and perspectives of our membership and those who are not members but who are partners or affiliates with us, to understand the information, the resource, and the self-care needs of CHWs, as well as trying to understand the opportunities to amplify this workforce and the ways in which this workforce is innovating during the pandemic. Next slide, please. So back in March 2020, we launched a national poll of our membership. As many of you may be aware, in the early months of the pandemic, many CHWs were actually being laid off or furloughed. Instead of public and private institutions and employers recognizing this critical frontline infrastructure workforce and the opportunity that it provided to engage deeply and authentically with community, a lot of our grant programs and our services were disrupted. And so NACHWA launched a national campaign to say that CHWs have a profound and urgent role to strengthen public health response during COVID-19. This is an example of a health affairs blog that was published in early May that brings forward a number of the voices of our membership. Yes, we are available and skilled in developing compassionate community engagement. We could also have been screening communities for social and behavioral health needs. All of us have now reconciled with the economic implications of this pandemic and understanding that behavioral health is a predictor of health outcomes and downstream chronic disease. As well, we understand that tens of millions of people who had previously not needed housing protections, eviction protections, they had not had food insecurity issues, now needed the services that many CHWs could provide. We also were centering the opportunity for CHWs to support the workforce development as public and private institutions were scaling up testing and contact tracing, and now are sort of repositioning and considering vaccination development and distribution. But we could also lead community capacity building efforts. It is my hope that some of the tens of millions or even billions of dollars coming through the federal government will be invested in community health worker-centered and led organizations so that we can come through and out of this pandemic with enhanced capacity, not reduced capacity. Next slide, please. CHWs are busy promoting equity and social justice. Early in the month of June, and a number of organizations out of Texas came together to highlight the profound impact of stigma and community violence that was being perpetrated against Asian American and Pacific Islander communities, or Asian American and Pacific Islander presenting individuals. So much so that a number of individuals were afraid to leave their homes to go to the grocery store. NACHWA partnered with a number of organizations in Connecticut, Camille Health Advocates, and also in Texas to bring forward this document, highlighting the ways in which community health workers can support these communities. There are ways in which we can ensure and advocate for increased and enhanced language access around testing and contact tracing and social care needs. The way in which the data that many CHWs collect needs to be disaggregated and analyzed so that we can dig deep into inequities in testing, inequities in contact tracing, and the ways in which CHWs can confront and dispel myths and racial discrimination that we're finding during this pandemic. Next slide, please. Answer it in a couple of different ways. First, I want to say that the CHW networks, associations, and coalitions across the country are organic to those geographies and those communities. In other words, they are not little NACHWAs, right? We don't own them. We don't set their agenda. You know, we're not their leadership. We are partners with them. And the National Association was founded to build a national infrastructure with organizations, some of whom have been in existence for decades. So I just want to sort of clarify our role with their role. So we always say that we partner with, even if those organizations are our members. The second thing, Oni, that is a challenge is because unlike many countries across the globe who operate what we call CHW programs, those are often centralized in the vein that decisions are made programmatically at a high level. Ministries of health, folks in government are on board and oftentimes are aware and or champions of some of these initiatives. In the United States, one CHW program in one city can look completely different than another, and they can never communicate. So when you talk about capacity to implement or evaluate or sustain a national initiative, you have to network many other CHWs who are working across sectors. That is the real work. That's why our organization came into being. Now, barring that, I also want to point you to the 47 states in the United States that already have CHW training programs. They already have legislation in their states that determine the scope of CHWs. There may or may not already be certification exams, licensure. In other words, there is much capacity in every state. Not every state looks the same, but we've got to begin acknowledging the capacity that is deep in community and make that connective tissue between that, the local health department, the state health department, and public and private institutions who are driving these task forces. One of the most frustrating messages that I was getting from across the country is that CHWs were saying, you know, I filled out that survey. I filled out that task force survey. The local health department contacted me by phone. I answered all of their questions about community, and they still do not center my voice as a leader. But now we see that some of the very things CHWs could have centered months ago about the need for care coordination, about the social needs, about the behavioral health impact was sort of late breaking news to some of these same task force because they did not have community leadership as decision makers. So there is much advocacy, Oni, that needs to take place. But when we talk about capacity, CHWs across the country have been building their capacity for decades. They have workforce studies that have been happening year after year. There are 6 decades of evidence to our return on investment and our efficacy. The American Public Health Association has had 2 decades of policy confirming our impact on health disparities and equity. So we're just here to sort of bring that to the fore and create awareness. The last thing I want to say in amplification of this workforce is on March 19th, 2020, the U.S. Department of Homeland Security classified community health workers as essential critical infrastructure workers. They sent recommendation and guidance out to all 50 states that CHWs should be paid to respond to COVID-19. But to my knowledge, to date, only 2 states formally adopted that language. That is part of the reason that
Which
many
states, Denise?
organizations were sort of closing down.
Which states adopted that resolution?
Yes, Massachusetts and California.
Thank you. And we have one final question for you from Frank Blanquet. Frank, unmute. Frank, you're on mute.
Hello?
Unmute.
Yes.
Sorry about that. Thank you, Sunita. Denise, you mentioned workers on the Navajo Nation. Can you comment on the importance of having and supporting CHWs that speak Native American or Indigenous languages and can communicate with community members that might not speak a dominant language like English or Spanish, as there's many south of the border community members that have these needs as well?
Oh, without question.